There are some discrepancy in the guidelines. If we see the American guideline, you will see the target is different. If you see the European guideline, the target again changes. So as per the European Society of Cardiology current guideline, anybody who has high risk LDL, high risk, I mean cardiovascular disease, their LDL cholesterol has to be less than at least 55. If you see the American guideline, ACC guideline, they are little relaxed. As of now, they do mention that LDL lowering is good for the patient, lower is better. But as of now, the target which they mention, they do not say anything less than 70. So 70 is definitely a target as per the American guideline, but they do not mention how low should we go. Contrary to our expert opinion, our CSI Cardiological Society of India recommendation, and as per our clinical experience as well, probably we cannot replicate the Western guideline of lipid target for our population because of the fact that our patient they do develop the atherosclerotic cardiovascular disease earlier, around 10 years earlier than the Western counterpart, and we develop this disease at a lower level of LDL. So probably our target LDL should be more stringent. So as per the Lipid Association of India, this is one of the, expert consensus. This is not actually a recommendation because this is not a guideline, but this is expert consensus, which suggests that anybody with extreme CV risk, the high CV risk, the LDL target should be less than 50, which we all accept actually. We all cardiovascular interventionists, we accept that anybody who has developed ASCVD or having multiple risk factor or very high risk for future ASCVD, LDL target definitely should be less than 50. Now, there are a group of patients who are considered extreme CV risk, very high risk. So they have different category as per the LI recommendation. But what we see, anybody who has recurrent event, in spite of proper cholesterol management treatment, or there is family history of premature atherosclerotic cardiovascular death, there the target should be very stringent, at least less than 30, and there is a optional target of reaching below 20, even 10, 15 milligram of LDL. So that is the overall consensus. In fact, we do follow this in our day-to-day practice. Fine. We can go to next slides. So these are, concern if we actually reach that low level of LDL cholesterol. Is there any problem? Is it going to give rise to different side effect or adverse reaction? To be very honest, all the doubts regarding the side effects with extreme low level of LDL are actually now out because multiple meta-analysis has clearly shown mostly the issue where chances of higher hemorrhagic stroke, cataract formation, neurological side effects, say for example dementia, those are actually not seen. The meta-analysis has clearly shown they are actually myth, they are not practical things. And you will be surprised to know that this apolipoprotein, which is very much responsible for transport of this cholesterol, mostly LDL cholesterol, they do not actually cross the blood-brain barrier. So all the issue of neurological side effect, hemorrhagic stroke, and dementia, they are actually impractical because, to be very honest, the homeostasis of cholesterol metabolism inside the central nervous system is independent. It is not dependent on the circulating level of cholesterol. And very honest, to be very honest, all the unit of our body, that is the cells, they have their indigenous mechanism of synthesizing cholesterol. So they are not actually dependent on the blood circulation cholesterol level. So all the possible side effects, they are actually now excluded. So we actually should reach, whenever indicated, to a very low level of LDL cholesterol. There are some ethnicity in the world, say for example, people like Eskimos and other congenital mutation where the LDL cholesterol is naturally very low, and they had been followed up for long. and they were found to have no side effect, no adverse reaction, but very lesser number of cardiovascular events, and as a result their survival is prolonged. So all the problem of reaching very low LDL cholesterol are actually not considered practical. Next slide. I'll share my practice. I follow a stepwise approach, because if we also look into the recommendation, many interventional cardiologists, they also feel that ACS, during the ACS episode, along with statin and other therapy, you actually can start inclisiran or PCSK9. But to be very honest, if you see the recommendation and guideline as well as evidence, they clearly suggest if someone develops ACS in spite of optimal statin therapy or other lipid lowering therapy, then only there is indication of starting this molecule in hospital during the index ACS events. Otherwise, you should follow a stepwise approach. You should, evaluate the LDL cholesterol every 1.5 months or so, which I follow in my practice. I go with initially high intensity statin, maximum tolerated dose of rosuvastatin or atorvastatin. If it is not achieving the target, then in my practice, what I do, I give another oral combination pill of ezetimibe and bempedoic acid. Many a time they are actually successful. And if that fails to bring the LDL cholesterol to the target, then only I consider inclisiran or PCSK9. Whatever prescription, whatever patients who are actually continuing this therapy, actually I follow this stringent, protocol. And to be honest, that is the approved indication. There is no doubt about the congenital dyslipidemia patient. They are the class 1 indication. But apart from this homozygous and heterozygous familial hypercholesterolemia, there are a group of patients where it becomes very difficult to bring down the LDL cholesterol to the target in spite of oral medication. They form around 10%, 5 to 10% of your overall patient population who undergo some sort of intervention, be it bypass surgery or angioplasty. They are also suitable patient for this kind of therapy. Ideally given at the baseline, followed by 3 months, then every 6 months. So 1.5 ml solution, it is available as subcutaneous injection, pre-filled. It contains around 284 milligram. So ideally at baseline, followed by 3 months, then every 6 months, so twice a year. That is the regime which the researchers has evaluated. I have already summed this up, and this is the CSI 2023 Kolkata guideline, which actually, suggests that anybody who is not reaching LDL cholesterol less than 55 with a stepwise approach are candidate for both PCSK9 or inclisiran therapy. We can go ahead. Phase 3 trial. There are two kind of trials with inclisiran. To be very honest, inclisiran now it is manufactured by Novartis, but it is not their research molecule. They bought it from medicine company. So you get two series of trials. Orion group of trial, Orion 9, 10, 11, they were all conceptualized as well as conducted by medicine company. Now then you get subsequent trials which are little event driven. They are conducted by Novartis. So Orion group of trial are the older trials. So initially they were conducted into heterozygous or homozygous familial hypercholesterolemia, established ASCVD, high risk ASCVD patient, mostly European and United States patient, and all of them showed that this is a very strong molecule to bring down the LDL cholesterol to the tune of around 50 to 55%, which is not seen with any other lipid lowering therapy. And then came the Victorian group of trials, which are now conducted by Novartis, and there are two kind of trial. One is event driven, another smaller group of trial are there which actually evaluates the atheroma volume by some invasive measure, either OCT and IVUS. So once they are ongoing trials, they are not yet available. So once they are available, our trust on this molecule, as well as from recommendation point of view, they will get much robust recommendation. Now, pooled analysis of Orion 9, 10, 11, I already mentioned, it's a very good, robust cholesterol lowering agent. There had been some Asian population in Orion 18 trial, where it was shown that lipoprotein little a, which is very difficult target, most of the lipid lowering therapy, they cannot actually lower lipoprotein little a. There was around 41% reduction with inclisiran, which was highly statistically significant. So that data is there. And this is the Orion 10 trial, which shows that inclisiran reduced the level of other atherogenic lipid and also increased HDL cholesterol to some extent. Okay, so inclisiran was generally well tolerated. To be very honest, only few injection site reaction. Those are the few reported side effects. Otherwise, almost like placebo-like side effects. Long-term safety, we already have data of around 10 years. So 6.8 years documented data, but if we take the follow-up patients, then almost more than 10-year follow-up patients are available. So as of now, no such, carcinogenic, immunogenic reactions were noted. Victorian, these are the group of trial. Victorian, these were conducted by Novartis. These are cardiovascular trial, but they are all ongoing trials. So they will evaluate the MACE reduction. Very high, expectation from this molecule, and I believe this is the molecule of future. And if it is properly directed, there are some trials which has started recruiting patients for primary prevention, which probably will be the answer, because no one wants to take a pill every day. Statin, one of the biggest limitation of statin, it has to be taken every day. But current, Gen Z, they do not want to take everyday pill. So there have been trials which are recruiting primary prevention patient, young patient. Once those data are available, this can virtually replace many of the players, many of the molecules of lipid lowering therapy. And this is truly a very futuristic molecule. And I strongly believe it has a very good prospect. We should bank on it. Thank you very much.